All right, I think I'm going to start, and a warm welcome to everybody who's just tuned in to take part in our nice webinar. I'd like to welcome everybody on behalf of the Eans tumor section. I'm the chair of the tumor section. I'm here together with the panel of the tumor section, and we are welcoming you to a webinar. The topic will be metastasis, and you will hear talks concerning surgical treatment, radiotherapy, and radiosurgery. We will also have a presentation that will include a view on modern and on more futuristic developments in surgical treatment of brain metastasis, and then something I'm very proud of. We have a medical oncologist with us, who is Philip Blumenthal from Jerusalem, and he will explain to us the medical oncology perspective, because at least in my opinion, this is something that's changing rapidly, and I think this will be a game changer for all of us. So welcome to everybody, and I think Christian will introduce the first talk.
Yeah, so thank you very much, Matthias.
Sorry, Christine.
It's okay, it's almost the same. Christine,
okay.
Christian, it's almost the same. So it's my pleasure to welcome our first speaker on stage tonight. It's Dr. Marcel Kamp. He's a consultant neurosurgeon from the University Hospital in Jena, Germany. He has a special interest in neuro-oncology and has published many papers on the resection of brain metastases, including surgical adjuncts such as 5-ALA. So Marcel, thank you very much for speaking to us today, and the stage is all yours now. Marcel, you have to unmute yourself.
Marcel, you have to unmute yourself.
To unmute yourself.
I think it's frozen, to be honest.
No, I think it's working. I can see him moving.
Yeah.
So, does it work now?
Yes. It works perfect.
I'm sorry for that. Dear chairs, ladies and gentlemen, thank you very much, Christine, for the kind introduction, and thank you very much for the invitation. Topic of this talk is surgical treatment of cerebral metastasis. And first, my disclosure: I'm a neurosurgeon, and this illustration shows a typical cerebral metastasis. And first of all, I would like to ask what evidence is there for the resection of single or few cerebral metastases in patients with controlled systemic disease? And if you do so and have a look at the relevant guidelines, resection of cerebral metastasis is recommended for single or few, large, symptomatic and superficial cerebral metastasis in patients with initially diagnosed or controlled systemic underlying disease. Here is an example, the IANO guideline, and here it states the therapeutic value of neurosurgical resection at least of single brain metastasis in patients with controlled systemic disease remains undisputed. These recommendations are supported by prospective randomized and controlled studies originating from the early 1990s. Here, for example, and I would like to take a closer look at almost one of these important landmark studies. Here are the studies which are from the guideline. The Petschel studies from the 1919 is the first ever RCT on cerebral metastasis and was carried out in the 1980s, from 1985 to 1988. Patients with radiographically proven metastasis were included. The radiological procedure was not further specified. Two arms were compared, namely the whole brain radiation therapy versus surgery combined with whole brain radiation therapy. And therefore, 48 patients were included, and in my view, very innovative. Complete surgical resection was controlled by an early contrast-enhanced CT within 48 hours after surgery. Whole brain radiation therapy was performed with a total dose of 36 gray and a cobalt radiation source. So these are the main results as shown by this Kaplan-Meier curve. The study found a statistically significant survival benefit in the group of patients with neurosurgery and whole brain radiation therapy compared to whole brain radiation therapy alone. But what I think it's important and should be kept in mind is that we base our therapeutic decisions on studies originating from the 1980s and the pre-MRI area. Radiotherapeutic and surgical therapies have probably changed completely. I don't want to question the value of surgery, but I think data are sparse. Again, here are cerebral metastases. How does standard resection of metastases work out? We assume that metastases are sharply delimited from the surrounding brain tissue. Therefore, surgery aims to peel them out from the surrounding brain tissue by microscopic circumferential stripping, and we aim to perform an en bloc resection. The aim of surgical metastasis resection is a complete tumor resection, achievement of the long-lasting local control, and preservation of neurological integrity of our patients. However, what are the results of neurosurgical resection alone in RCTs? The EORTC study with Martin Kocher as first author gives us some insights. Here, patients after complete metastasis resection were included, and the local recurrence rate, depending on the adjuvant therapy, was assessed. Here, the Kaplan-Meier curve only for the arm with surgery and observation shows the local progression rate in the surgical arm without any adjuvant radiotherapy. And in this arm, the local in-brain progression rate was almost 50%, as shown here. This means that about 15% of our cases, we do not achieve the goal of a long-lasting tumor control through neurosurgery alone. And I would like to question this and examine two reasons and possible solutions for that. We neurosurgeons classify the degree of surgical resection intraoperatively and say that we have achieved a complete surgical resection when we see no residual tumor through our microscope. The histological verification of completeness of our surgical resection according to the R-grad of the TNM classification does not work in the case of classical circumferential resection. Therefore, the question arises whether we leave behind unexpected tumor residues even in complete neurosurgical resection, and whether this is what might be the starting point for a later local in-brain progression. So in Düsseldorf, we have usually performed an early postoperative MRI within 72 hours after surgery and retrospectively analyzed in different series how often we can detect neurosurgical tumor tissue in resection intraoperatively classified as being complete. And here you see the three different series for primary diagnosis, for recurrent metastasis, and for elderly patients. And in all the series, in approximately 20 to 25%, we were able to prove unintended tumor residues, and in additional approximately 20%, we could not reliably assess a degree of surgical resection in an early postoperative MRI. And what's I think it's most important, postoperative tumor remnant was the only predictor for later local tumor progression. Here is recent retrospective studies summarized here that have analyzed the significance of perioperative residual tumor verification. The Cologne group, here is work by Jünger et al., could not find any connection between residual tumor after surgery and local brain in brain progression or survival. Contrary, here the Scandinavian series, for example, the recent series by Winter, the detection of residual tumor is not only a predictor for local in brain progression as shown here, but also for the overall survival. This question can finally not be answered with the data yet, and we do require better and more studies. However, if we assume for one moment at least that residual tumor favors later local progression, are there any methods to better intraoperatively localize residual tumor? And based on the Stummer studies for the glioblastomas, we firstly thought of 5-aminolevulinic acid, 5-ALA. And indeed, depending on the patient collective, we observed 5-ALA fluorescence of cerebral metastasis in up to 60%. However, we observed no association of the qualitative 5-ALA signal and the histology or primary site. This is one of the series, and in this series we observed 30% of ALA positive signal in totally 280 patients, but not statistically significant association between the 5-ALA signal and the degree of neurosurgical resection. However, we identified a trend towards the significance of the 5-ALA signal and the local occurrence rate, but it was not significant. And we identified the 5-ALA signal as an independent predictor for the overall survival. However, this does not help intraoperatively very much. And the question arises, can we use the 5-ALA signal to visualize residual tumor parts? A recent retrospective studies addressed this question in a series of nearly 30 patients. Of these 30 patients, 85% of metastases were ALA positive, and the colleagues histopathologically analyzed the tumor infiltration of the 5-ALA fluorescent and non-fluorescent perilesional tumor brain interface. And the authors found a significant correlation between the 5-ALA signal, the fluorescence, the non-fluorescent signal, and the perilesional tumor infiltration. But 5-ALA fluorescence of the perilesional infiltration does not necessarily mean that this tissue is infiltrated by tumor. Here you see the fluorescent tissue, and you see in 15 of totally 64 samples, no tumor infiltration. And here I have one of our own examples, which is a 5-ALA negative metastasis of an NSCLC with positive perilesional tumor brain interface. Here we could not detect any tumor infiltration of this fluorescence perilesional tissue. Therefore, 5-ALA fluorescence-guided resection of perilesional tissue without an adequate neurological control, for example, by awake surgery, is, in my view, not a complete safe method. But what's about fluorescence? Our Innsbruck colleagues have analyzed this retrospectively in a series of 69 metastasis patients. Here too, there was a clear discrepancy in the intraoperative assessment of complete surgical resection, which ranged, I think, about 95%, and the postoperative evidence of a complete resection. However, the use of fluoresceins in 53 patients was associated with a higher rate of complete surgical resection, here, and a local recurrence rate. I personally have not very much experience with intraoperative of fluoresceins in metastasis surgery, but I'm not completely convinced that fluoresceins is a golden bullet in metastasis surgery, but we might discuss this later. But at this moment, I would like to step back. Our surgical technique is based on the assumption that cerebral metastases are histologically sharply demarcated from the surrounding brain tissue. But is this really the case? And I have to say no. If we have a closer look, we observe infiltrative growth pattern as shown here, or irregular tumor brain interfaces with finger-shaped extension and vascular cooption. Here is somewhat older literature review, and we see a sharp delimitation of metastasis from the surrounding brain tissue in only here or here, in only 30 to 60% of cases, and an irregular infiltrative pattern or a vascular co-option here in up to 60% of cases. So, is an irregular or infiltrative growth pattern of cerebral metastasis a reason that we can intraoperatively not detect microscopic tumor invasion and leave residual tumors behind? Possibly, but it's hard to prove. And here we have no or not enough literature. But is there an opportunity to address this problem? So here, visualization of the tumor rests. Possibly. We might address this problem if we extend the degree of surgical resection toward a supramaximal or supramarginal resection. Therefore, we perform a gross total resection as we do it normally. And after a complete surgical resection, the resection is extended at least circumferentially about 0.5 to 1 centimeter. This South Korean working group was first to examine supramarginal resection, here designated as microscopic total resections. Gross total resection were extended circumferentially by 0.5 centimeters in non-eloquent areas and compared to gross total resection in eloquent areas. 95 patients were included, and microscopic gross total resection with and without radiotherapy was compared in these 4 groups. Here are the local recurrence rate, which is in the microscopic total resection group with radiotherapy, 0% in 10 patients. So postoperative radiotherapy here and the extent of the surgical resection were the only significant predictors for later local progression in the multivariate analysis here. And this is also shown by this Kaplan-Meier curve again. And you'll see here the groups, and we found no local recurrence in the microscopic total resection group and radiotherapy group. A few years ago, we also evaluated a small series of our own patients with supramarginal resection, and we assessed in 34 patients with single cerebral metastasis the neurological outcome as assessed by the NIHS score pre-post operatively and in the follow-up. And we see no significant permanent deficits, but we observed in 5 patients with about 15% temporary deficits resulting from supplementary motor area deficits, and which improved in about 2 weeks. The local progression rate was comparatively low with nearly 15%, in particular if you compare it, for example, to the EORTC study, where local progression rate was about 25% in the group of surgery with adjuvant radiotherapy. And these results are also verified by a recent Chinese study with totally 48 patients with supramarginal resection of brain metastasis of non-small cell lung cancer. And here you see this quite heterogeneous group, which is quite normal in my view for this patient collective. And again, in the multivariate analysis, the number of brain metastases, the extracranial manifestation of additional metastasis, and the degree of surgical resection were the only predictor for later progression. And this is also shown here in this Kaplan-Meier curve, where the recurrence-free survival is shown. And you see here, the black line is a supramarginal resection group, and this is the gross total resection group, and you see a significant difference. In my view, supramarginal resection should only be performed if essential cortical and subcortical functional example with neurophysiological monitoring and or awake surgery can be guaranteed. And we have to ensure that we preserve neurological functioning of our patients here by monitoring cortical, supracortical structures. So this is the point where I want to finish this thing. And I think we have to question if the surgical goal of achievement of a complete resection in certain situations is the only way. From my point of view, the extraction and genetic and epigenetic analysis of tissue is also of big and increasing therapeutic value. And I want to give an example from 2010. Ding and colleagues firstly genetically and epigenetically analyzed the tissue of a basal-like breast cancer primary site and cerebral metastasis and found significant genetic differences marked here in red. This is a difference between the primary site and the metastasis. And the Brastinos lab performed similar analysis of the primary site and different and recurrent metastases and were able to show genetic family trees, which I think is very, very interesting. For surgical resection, however, we have to evaluate the burden of symptoms, in examples through palliative care screening, malnutrition screening, quality of life screening. This also has to include evaluating the needs of a specific group of our patients, for example, geriatric patients, which we do in Jena. And we should analyze whether certain patient group are particularly well or badly suited to surgery, and on the other hand, how surgery affects these conditions. An interesting context in this context is, in my view, the concept of the so-called cognitive reserve, which my colleague Januzzi is currently evaluating in our metastasis patients. And finally, however, I'm also convinced that training is an important point and that we must continue to advance new and innovative neuro-oncological training concept. I'm very pleased that we defined international competencies and trustable professional activities for our neuro-oncological training here last year. And I'm also very pleased that we're currently trying to put these into concrete terms, both in the neuro-oncological working group of the German Krebs Society and as well in particular departments such as Düsseldorf. Therefore, I want to summarize. I think the data on the importance of surgery is not very good in some cases, although I'm very convinced of the surgical concept itself. I believe that postoperative residual tumor is a predictor for later tumor progression, but again, the evidence is not very good. We should further clarify methods for the detection of tumor residues and further evaluate new concepts, such as the concept of supramarginal resection. I also believe that obtaining and analyzing tissue, even repetitively, is important. And I believe that education and empowering of our young colleagues is utmost important. And thanks a lot.
So thank you very much, Marcel, for this very nice, very interesting and well-balanced presentation, I think. There are also always, there are already questions from the audience, actually, and regarding the impact of 5-ALA mainly. So one of the audience asked whether there is a difference with 5-ALA positive tumors with and without edema, and whether there is a difference regarding or depending on the primary tumor. Could you comment on that, please?
First, the ALA question. I think that the false positive detection of 5-ALA signal in the perilesional area is caused by tumor edema, and I think that's a very important factor. And I would not completely rely on the 5-ALA signal in these areas. We frequently see that there are tumor infiltration, no tumor infiltration despite a strong fluorescent signal. And the second question, I think supramarginal resection is a good concept, but the data is we have only 3 studies analyzing this, or 4 studies analyzing them. We need much more data. I think it's much often performed than reported, and I think it might be a good conception if we can control neurological function. Perhaps it might be an idea to do a study.
That would be worthwhile, definitely. There's one more question regarding the tumor subtype. Can you correlate the tumor subtype or the primary tumor with a 5-ALA signal?
We see no association with a qualitative 5-ALA signal between the signal, whether it's positive or negative, and the histological subtype or the primary side. But we also have, I haven't shown the thing yet, we have also performed quantitative analysis and measured the 5-ALA signal, and therefore we see a correlation.
Okay. Any more questions? Yeah, Matthias.
Hello, thank you, Marcel, for this very nice and balanced talks. I actually have 2 questions. Since your talk is basically about conventional surgery in patients with brain metastases, what about surgical indications in cases with multiple brain metastases? And another question that I have, what about redo brain metastasis surgery? What are indications to operate again on a patient with a brain metastasis at the same site?
Yeah, thank you both for this very important things. I think indications for multiple metastases are changing, and we do more frequently surgeries on 2 or 3 cerebral metastases, and I think the number of metastases alone, for example, 2 or 3, if you have few metastases, should not be a reason to do surgery and not to do not surgery. And also from a palliative care view, I think we can do a lot of improvement of the burden situation of patients if we do surgeries on multiple metastases. Regarding the question to the recurrent metastases, I think that's a very interesting question, because in my personal view, often patients can't receive an additional irradiation therapy because they received 1 or 2 or even more radiation therapies, and here surgery is a good option. In particular, if you have no medical option. I think we will hear this later. But again, we have analyzed this also in a studies, and data are very sparse about this. The complication rate might be might be a little bit higher, but I think it's a good option. I hope I've answered the question sufficiently.
Marcel, maybe one more question. We will address the role of medical oncology later on, but do you think that recent developments in medical oncology, such as immunotherapy, for instance, also changed the surgical decision making? What's the interaction?
Yes, yes, it does. First of all, I think obtaining of and analysis of tissue is more important, as you can detect mutations and can make indications for targeted therapies, and I think that will be increasingly important. However, not all of the targeted therapies are override the blood-brain barrier, and I'm not completely convinced of a strong role of the medical therapy in cerebral metastasis. We observed really good results, for example, for ALK translocated cerebral metastasis, or sometimes for PD-L1 BRAF/MEK inhibitors. But many of these studies, if you see in the phase 3 studies, observed a stable phase for about, well, I don't know, 4 months or something like that. So I think it's becoming increasingly important, but the main domain is still surgery and radiotherapy in the treatment of cerebral metastasis.
Okay, thank you very much. Maybe Dr. Blumenfeld will comment on this later on as well. So if there are no more questions, any questions from the panelists maybe? And not from the audience. Thank you very much again, Marcel, for this well-balanced talk. And yeah, I would like to hand on to the next speaker, which is David Metuka.
And then it's a pleasure for me to introduce David to all of you. David is a professor and the chair of neurosurgery at Prague Military University Hospital. And he has a great interest in all things neuro-oncology, also vascular, of course. And one of his specific interests, I think, is pituitary. And then there's a bit of skull-based meningioma. And this is somehow how he also has formed his own views on stereotactic radiosurgery and radiotherapy. And this is why we have invited him to explain to all of us what he thinks what stereotactic radiosurgery may mean in the patient with brain metastasis. David, we are looking forward to your talk.
Matthias and all the panelists, thank you very much for kind invitation. I'm really happy to have this high-end topic about stereotactic radiosurgery for brain metastases. And I have several disclosures. I'm a neurosurgeon. I'm very much involved in neuro-oncology. And I believe that we should be really deeply involved in neuro-oncology, and we should be involved in radiosurgery. And I want to disclose that I have a bias toward cyberknife surgery because we opened our cyberknife unit recently. Just a short introduction. This is our cyberknife unit. We cooperate with our colleagues and friends from radiation oncologists, but neurosurgeons are the key players in the team, and we are very much involved. Me and my two colleagues, Dr. Kramach and Dr. May, and this lady was principal in setting up this lecture. So I would like to thank her once more. This is our cyberknife unit. And of course, we can speak about different types of the radiosurgical treatments. We can speak about the gamma knife. We can speak about the future development of ZapX or Novalis. But let's go back to the topic of stereotactic radiosurgery. Should we, neurosurgeon, be involved, or we should just send the patients for the stereotactic radiosurgery? I'm very much convinced we should be the key player because we know where either the tumor is located or there's a residuum of the tumor, or we should perform pre-op radiosurgery or post-op radiosurgery. So we should not be like consultants, but we should be a key players. Once more, I am basically the neurosurgeon doing a lot of cranial stuff, including the brain mets, gliomas, skull-based tumors, and I am, let's call it, open neurosurgeon, but I see the role of the stereotactic radiosurgery, and I see the expanding role of SRS. Why? If we go to whole brain radiation therapy, and we have our colleagues on the panelists, we see the cognitive adverse events like fatigue, somnolence, learning, and memory impairments. And we know that the prognosis of our patient with the brain metastasis is not the best one. What about SRS alone? Is it a favored treatment approach in patients with limited number of tumors? And we have to focus on the fact that it's a targeted, conformal, and in some cases, a single session, even though that I'm going to speak about the hyperfractionation of the SRS. But if we go to the studies, well-described studies about the effect of radiosurgery alone versus radiosurgery with whole brain radiotherapy, there is less cognitive dysfunction and fatigue in these patients with a modest life expectancy. And what is very important for me as a neurosurgeon, I either want to perform early surgery or early radiosurgery or combining, but there is a need for delivery of secondary treatment. And if you look at the delay to secondary treatment, SRS is a perfect tool. No wound complications and patients in good condition. If we look to the data, whether we should combine whole brain radiotherapy or with only or whole brain radiotherapy plus SRS for a single brain metastasis, yes, we see that if we add radiosurgery, there is a significant improvement and advantage over the whole brain radiotherapy alone. If we combine the addition of the stereotactic radiosurgery confers a survival benefit for patients with good prognostic score. But that's not the whole story which we are going to discuss. What about if we compare the SRS alone and whole brain radiotherapy for the patients with less than 4 brain metastases? I don't have enough time to go into details of these 3 landmark randomized trials analyzing this comparison, either SRS alone or whole brain radiotherapy. If we add whole brain radiotherapy in general to SRS, it doesn't improve patient survival. And if we don't add the whole brain radiotherapy, there is a lower risk of cognitive dysfunction, as I mentioned, if we use SRS alone. Of course, we should know the risk if we go for SRS alone. Yes, there are slightly higher rates of new brain metastases distant to brain to the resected tumor and irradiated tumor if we use SRS alone, but local control rate is really high if we use SRS alone. And based on these results, if you look to US and European guidelines, there is a trend. I would not call it like a strict rule, but a trend to go for SRS. And I am strongly convinced we should be really deeply involved in SRS for our patients and to consider whole brain radiotherapy only in selected cases for the patients with the brain metastases. So these are the citations. About the expanding role of SRS, I want to focus your interest on this prospective study from Japan on 1,200 patients with less than 10 brain metastases and SRS alone. What is about the median survival? It's similar to if the patient had 5 to 10 and 2 to 4. Toxicity rates are similar, neurocognitive function similar, neurological deaths, new brain metastases, and need for salvage therapy the same. There is a very crucial point and very crucial question. What about the leptomeningeal dissemination? And if we look at the patient with 5 to 10 brain metastases and we use SRS, there is slightly high risk of leptomeningeal dissemination. And this I will repeat several times in my lecture. Let's keep this in mind whether we increase the risk of leptomeningeal dissemination if we go for SRS alone. What about the regimes? If we go for hypofractionation of SRS, 3 to 5 treatments, which we use routinely, it's increasingly used for brain metastases, and we decrease the risk of the surrounding organs if you use the hypofractionations, especially for the optic nerves and chiasm, and in some cases for the brainstem. We, as a neurosurgeons, in the past, we believed only in head frame based SRS, which is an excellent tool, but in the recent years, it has been increasingly replaced by frameless guided SRS. Why? There is a proof of greater comfort and flexibility of scheduling for the patients, and no differences in adverse effects and treatment outcomes for our patients. This is based on Moachevi's study already from 2010. What about SRS for resection cavity versus post-operative whole brain radiotherapy? If we go only for SRS for the resection cavity, there is an improved neurocognitive presentation. And again, we have to face the reality. There is slightly lower local control rate, about 20%. But what is the reason for that? There have been numerous discussions about the delineations of the contouring of the resection cavities, and based on the consensus of contouring guidelines for SRS, the results are recently improved. What are the hot topics in SRS versus whole brain radiotherapy for the treatment for brain metastases from the perspective of a neurosurgeon? I'm not radiation oncologist, I'm not medical oncologist. So this is my personal perspective. Primary SRS, either for single or multiple brain metastases, either single session, hypofractionations, 3 to 5 sessions, volume stage SRS. What about value of postoperative SRS? And what about pre-op SRS? Do we use it? Is there a future for that? So I will try to answer all these questions in the following slides showing the evidence. So what is voluminous metastasis for SRS? So this is a nice study for the cumulative intracranial tumor volume greater than 7 mils. And this study was focusing on feasibility of upfront SRS for these brain metastases. This study group looked at 234 patients. Median overall survival was 8.7 months, and 6 months overall survival was 60%. As typical, there are some predictive factors. If there is a systemic anti-cancer therapy, well, we improve the outcome. If there are less brain metastases, the outcome is better. If there is controlled extracranial disease, yes, and better prognostic status. What is very important for me, because I see these patients, the toxicity rates were really low. For grade 5, only in 1 patient out of 232. And let's face the reality, if we do treat 232 patients with the brain metastasis, we will have more complications than 1 grade 5. And what about the salvage management? Yes, we can repeat SRS. This was in 1/3 of the patients, whole brain radiotherapy in very small cohort, and surgical resection in 10 patients altogether. So if we go for the higher volume metastasis, and if we go for a really vigilant surveillance and salvage management, the upfront SRS can be considered even for these somehow called voluminous intracranial tumor metastases. So one case example from our series, 70-year-old woman with known primary cancer, left-sided hemiparesis and facial palsy, 3 metastases. Biopsy proved the source of the tumor, the histology metastasis of tubular carcinoma, and the PET study was performed. And even in these quite voluminous metastases, we go for SRS. And we plan the treatment with this dose of 32.5 grains in 5 fractions, because we can hyperfractionate, and the patients are tolerating these procedures very well. What about the staging and toxicity? If we go for a big metastasis, we start with the treatment with SRS, and then we continue in 2 weeks or in 4 weeks. In this study focused on brain metastases greater or larger than 10 cubic centimeters in 43 patients. And this was the peripheral dose. And is it feasible to address these large metastases with SRS, or it's dangerous for our patients? So these are the mean tumor volumes at the time of the second and the third fraction. So we start with the lower volume, with the high volume, then there's a reduction of the volume of the metastasis, and now there's the third session. So the local tumor control rates were promising, and it was proven that with the 2-week interval, this allows for the reduction of the treatment volume and reduction of the risk of the treatment. So case from Gamma Knife unit in Prague, known primary lung cancer, several symptoms, new metastatic lesions in the cerebellum, 2-stage Gamma Knife radiosurgery. So this is the first session. This is the volume of the treatment metastasis. You see here and here. And after 2 weeks, there is a significant reduction of the tumor volume. And second stage is much safer for the patients. So when we change the topic, when we go for the post-operative radiosurgery after the excision of the brain tumor, we should face the reality that we don't have a very good data. And this is a nice study about the outcomes of SRS. And this group analyzed the results based on the literature data. They included 55 studies and included almost 3,500 patients. And they looked at a local control rate at 12 months. It was 83%. And it was pretty obvious if we go for fractionations for SRS, it's better for the local control than single fraction. If we look at the local control rate with at 12 months, with addition of the margin, there is no significant difference. But radiation necrosis, 7%, and big topic, leptomeningeal disease, 13%. So based on this survey, based on this meta-analysis, the fractionated SRS appears to be beneficial and warrants further treatment. So this example, 62-year-old patient with the known pulmonary carcinoma, several symptoms, and huge metastasis in the right cerebellum. But altogether, there were 5 brain metastases in the cerebellum. We resected the 3 largest ones. So we had 3 resection cavities and 2 small, tiny metastases left. And all the 3 resection cavities and 2 metastases were irradiated using SRS. So this is the first preoperative, second postoperative MRI. So pre-op and post-op, and you can see that the dose distribution is favorable. So here is the high dose of radiation and the dose for the organs at risk. So pre-op and post-op, and we can irradiate the resection cavities as well as small residual tumors. So going to the end of my presentation almost, is there any role of preoperative SRS? Should we consider this? Does it help in respect of local control, leptomeningeal dissemination, and the radionecrosis? So this study looked at the efficacy and toxicity of preoperative SRS, and these colleagues used the SRS and the surgery within 2 days after SRS. In this study, 117 patients with 125 lesions were included, and in most cases, single fractionation postoperative SRS was applied. So we did the surgery, again, my primary field, gross total resection in 95%, median time from SRS to surgery. So pre-op SRS, then surgery was 2 days. And even cumulative incidence at 2 years, cavity local recurrence was 25%. And we see that leptomeningeal dissemination was only 4.3% and symptomatic radionecrosis only 5%. So it seems that the 2 years overall survival of 36% is rather favorable for this group of patients. And this radiation therapy is favorable for the treatment. So single fraction preoperative SRS confers excellent cavity local control, and the risk of radionecrosis and leptomeningeal disease is pretty modest. And maybe we should discuss it more deeply, whether we can reduce the following risk of our surgery with the preoperative SRS. Of course, the following lectures will focus on more modern techniques, and this is the list of the techniques, and I believe that we should join our forces: surgical SRS, whole brain radiotherapy, and medical treatment and novel treatments, and then we can improve the outcome of our patients. And going to conclusions, upfront SRS is safe and effective treatment strategy even for brain metastases with the volume greater than 7 milliliters. Stage SRS allows significant reduction of the treatment volume and may be alternative for treatment of large brain metastases. Post-op SRS to resection cavity is a safe and effective regime and appears to be beneficial and warrants further exploration. And single fraction pre-op SRS confers excellent cavity local control and is reducing the radionecrosis risk due to smaller irradiated volume and reduce the risk of leptomeningeal disease. Thank you very much.
Well, thank you, David. Thank you for this very exciting talk. Let me see if we have any questions. We actually have a very technical one. The question is, which margin dose was delivered for pre-surgery radiosurgery?
Okay. So. Just to be very open for this pre-operative stereotactic radiosurgery, I don't have it in my slides, and to be honest, I would if the person who is questioning this question sends me a request for that, I would go, because I don't want to be imprecise in the dose discrimination. So just send me an email and I will look at it once more, and I will answer that via email. Sorry for that.
All right, so there's a second question in the Q&A box. Do you have experience with radiosurgery for multiple mets and immune and targeted therapy?
In our setting, the most patients get multiple SRS, but immunotherapy is used less frequently. So this combination is used only on the case reports in my country, and we typically combine the other techniques. So again, it's a bit negative answer, but it's more in the articles than in daily practice, I have to say.
Thank you. I'm looking if anybody else has a question. Christine has one.
Yeah, thank you very much, David, for this very nice talk. It's rather a philosophical question. You stated in your disclosures that you're a neurosurgeon, and in the US, it's very common that neurosurgeons do radiosurgery. In Germany, it's not. Do you think it influences your decision-making in both ways, whether you go for radiosurgery or for neurosurgery?
Well, thank you very much for this question, which is a bit easier for me to answer. I believe we should be really involved, not just to be a consultant in radiosurgery. And in the beginning of my lecture, I showed two colleagues from my team who work half-time job at radiosurgery at the CyberKnife and half-time job at the open neurosurgery. So I think we should be neurosurgeon practicing both and not to be consultants. So then I can use what is the best from the open surgery and let's call it in my department from the CyberKnife surgery. So we should be doing ourselves CyberKnife or SRS, and then we can decide what is the best for our patient. So I would call for being for higher interest for the neurosurgeons and to be involved deeply in SRS because it's beneficial for our patients, and we as neurosurgeons understand the best the imaging, the value and the risk of the surgery. So let's keep this field as a field for neurosurgeons.
Thank you. I think Philip has a question. Please, Philip.
Thanks so much, David, for a wonderful lecture. One comment and one question. The comment is we're all kind of, you presented very nicely the Alliance data and post-op SRS showing some reduction in local control. I'll just let the audience know that just about a month ago, they in a couple months ago in Astro, in the late-breaking abstract, actually presented after central review that there was there was actually potentially an improved local control in the SRS arm. So something that we would actually we were more likely to kind of nod and accept. So we were happy to see that data, but we're very much looking forward to the multi-fraction versus single fraction and post-op SRS. As definitely an area that we can explore. I was just wondering, David, if you in your practice have started to do preoperative SRS, and if in that case, how much time interval would you recommend between the surgery and then the radio surgery and then the surgical intervention?
I try to be very open about this topic. I mentioned this topic in my lecture that there are some studies, and I showed one of these studies, and we discussed with our CyberKnife unit and radiation oncologist this topic, and we indicated the pre-op SRS in young patients with good prognosis, but we have a very modest experience with the 6 patients only with the breast metastases and pre-op SRS and the surgery followed. And of course, I cannot draw any conclusions. It's an ongoing field of interest for us, and we do not have the firm results. So we should await for the further data, whether they will be promising as I presented in my lecture, or whether we will stop using this. So only very limited series of young patients with the breast cancer.
Thank you, David.
Thank you very much.
David, there's another probably technical question. I wonder if you know that if you compare whole brain radiotherapy versus whole brain radiotherapy with stereotactic radiosurgery, do you adjust the dose, I assume, for the whole brain radiotherapy, or is it just the same type of whole brain radiotherapy? Probably a question for radiation oncologist.
That's for the radiation oncologist, but to be open again, we try, it's not against the radiation oncologist, but we try to go for SRS even for multiple lesions, and then in case of recurrence to go for again. So in a very limited number of patients, we go for whole brain radiotherapy nowadays, to be honest.
Okay. I think we have to go on, but one final question, short answer. Small metastasis in the primary motor cortex. Oof. Patient does not have a deficit. Would you go for open surgery in order to preserve function if you get lucky and nothing happens, or rather for radiosurgery and maybe have some brain swelling and some neurological deterioration?
Okay, so well, that's a very good question, Matthias. So the how do based on which data you assume it's a primary brain cortex if the patient has got no deficit? It's
MRI,
okay, so based on MRI,
TMS.
okay, so most probably it's close to the primary motor cortex if the patient has got no deficit.
Okay.
If it is a younger patient with good prognosis in general, and the metastasis is very close to the cortex, I would consider open surgery with the monitoring, of course. If it is an elderly patient, I would go for SRS.
Okay. Thank you. I think there are no other, well, burning questions. So I'm going to hand over to Jerry Bartek, who will announce the next speaker. Jerry, please.
Thank you, Matthias. So it's my pleasure to present Dr. Clark Chen, who's a professor and head of department of neurosurgery in Minneapolis, Minnesota, in the US. And he has obviously a subspecialty in the field of neuro-oncology with long experience in research within both clinical as well as preclinical and translational research. And he's also an expert on novel neurosurgical techniques. So we thought that he'd be the perfect person to deliver a talk on neurosurgery beyond resection. So thank you for accepting our invitations, Dr. Chen, and welcome on the behalf of the neuro-oncology section of the ENS.
Well, thank you, Yuri, and thank you, Matthias, and the ENS for the opportunity to present this work. Let's see, this is the correct presentation mode. Is that correct that we're seeing? All right, so I'm going to address a topic that is increasingly important in my practice and in many of my colleagues' practices, which is the brain metastases that recur after stereotactic radiosurgery. You know, as you have heard from, let's move forward. I guess I'll do this. These are my disclosures. I'm a consultant for de novo, MRI intervention, variant, and Medtronic. So we'll first give you a little background on brain metastasis that recurs after radiosurgery, and then talk about this idea of laser ablation combined with consolidatory SRS as a option. And at this point, this really is just an option. So as you heard from the previous two talks, radiosurgery is an extraordinary tool. You know, it has its origin in Karolinska, Yuri's home institution, and since its inception, it has revolutionized how we treat patients in neurosurgery. Now, I think all of us would agree that radiosurgery is an excellent treatment option for brain metastasis. Sorry, that's there's been 5 randomized control studies, and some of which were referred to in the earlier presentations, that looked at the local control for stereotactic radiosurgery. And the reality really is, for brain metastasis, if you don't live past a year, it really doesn't matter how you treat it, right? And some of our perception of radiosurgery may be biased by the historical observation that most brain metastasis patients will die within a year. And so if you're going to die within a year, what you really do for that metastasis hardly matters. As we see more and more impact of targeted therapy and immunotherapy, which we're going to hear more about later on in today's session, how we treat brain metastasis becomes more and more important. And if you look at the 5 randomized studies that has been published to date, the local control rate for brain metastasis at 1 year is somewhere on the order of 70%, right? So, and more in my practice, I see patterns like this. You can see this is a breast metastasis that I treated with stereotactic radiosurgery, and it shrunk. This is a beautiful result. We all love to see this. But then what happens to this patient? This patient received targeted therapy. She lived out 2.5 years, and look at what happens 2.5 years later. You could see this weird fuzzy pattern, and that becomes, well, what do you do with this? Well, it turns out this is a recurrent metastasis. there's active tumor in this when we biopsied it. So what do we do when we see these patients? And more we're going to see these patients. We're going to see more of these patients for 3 reasons. One, the demographic of all of our populations are getting older, and cancer is a disease of the elderly. So the incidence of cancer will go up in the next decade or 2. That's just a powerful demographic change that none of us could change. As more people get cancer, more patients will get metastases, right? And so this is going to be a growing issue. The second is with the impact of targeted therapy, immunotherapy, and all the advances in surgical therapy and radiation therapy, people are going to live longer. And the longer you live, the more likely you'll suffer metastasis, unfortunately, if you have cancer. And the last thing is many of the targeted therapies or antibody therapies do not cross the blood-brain barrier. And so this becomes a sanctuary for tumors to grow. So we're going to see more and more of brain metastases that recur after radiosurgery because the number of metastases will go up. So what do we do? Well, again, I'm looking forward to the systemic therapy talk. This is, in my practice, if a lesion is small, and what I mean by that is sub-centimeter, I think it's reasonable if the patient's getting systemic therapy that crosses the blood-brain barrier at a reasonable, concentration. It's reasonable to observe closely with very short interval MRIs. I have seen remarkable responses with patients with small metastasis on immunotherapy. I've seen notable responses of brain metastasis on particularly, ALK targeted therapies. So for smaller lesions, this is a quickly evolving field that we all have to learn more about. But in my practice, many of the smaller metastases, we would observe in smaller short interval MRI and only act if there's progression. For the larger lesions, so surgical resection, which you heard a wonderful talk about, remains a mainstay. And for those patients who are not surgical candidates, repeat SRS is often performed, as you heard. The problem with repeat SRS is that the risk of symptomatic radiation necrosis goes up. I mean, I've given you a review of the literature here, where you look at, if you look at adverse radiation effect, and these are clinically relevant symptomatic effects, they're, in the 20% range, okay? And radiographic radiation necrosis is probably higher than that. So is there a better option? Now, repeat radiosurgery may not be a great option for all brain metastases that recur after radiosurgery. For one thing, some brain metastases are just intrinsically resistant to radiation. Here's a paper that we published many years ago looking at melanoma that went to the brain. And we did expression profiling here. Shown on the y-axis here are a number of DNA repair genes. And then each of this column is a patient. And what you can see here is the metastatic melanoma that went to the brain has significantly increased expression, as indicated by red here, that's indicating high expression, relative to their sort of parental tumor, if you will. And so these tumors are intrinsically radiation resistant. And in fact, if you were to look at control rate for melanoma, I mean, the 12-month control rate for melanoma, depending on the size and the dose, can be as low as 60%, which is unacceptable. So do we have a better option for these patients, right? And certainly systemic therapy is one option. The other thing is that what you heard about, which is that for critical neuroanatomic structures, such as the optic nerve, the brainstem, we're limited in the amount of dose we could deliver in repeat radiosurgery. And in fact, if you look at this beautiful work that was done on the bottom here, I think someone else is moving the mouse. This is not me moving the mouse, unfortunately. Is someone else moving the mouse? Thank you. If somehow this mouse is drifting in a ghost-like manner and I can't control it, is someone else controlling the mouse? Anyway, if you look at the bottom panel, now this is beautiful work done by the work at Pittsburgh. The tolerance of the tissue, 212 gray. Did someone just advance my slide? I'm sorry, let's move back. Now I could, the tolerance of the brain to 12 gray volume is an important consideration. And these are things that limit our ability to give repeat radiosurgery. So now I'm going to talk to you about how laser ablation, which was referred to in the earlier talk by David, may be incorporated in the treatment of these brain metastases that recur after radiation as an option, right? So what is laser ablation? This is a cartoon illustration. Effectively is a stereotactic procedure where we insert a laser probe into the tumor. In some vendors, they have directional capacity where you can heat up the tumor and turn the laser, and because the laser fires from the side of the laser probe rather than as a spherical volume. So the bottom line is, as you induce laser firing, you create hyperthermic injury to the tumor, resulting in ablation, destruction of the tissue. Now, the really cool thing in my mind when I saw this initially was, it kind of blew my mind, is that the MRI could serve as a massive thermometer essentially, and you could monitor the heat propagation in real time. I'm showing you this for one reason, and I will tell you what that one reason is. But just if you imagine, this is each pixel represents the temperature, or rather the color of the pixel represents the temperature. And what you can see as you start firing the lasers, you could start seeing that the green pixels become eventually yellow, red and yellow. You can see these pixels emerging as we heat. And you can see eventually that you could see regions are heated, and you could turn the laser probe around and you could contour the heat to the lesion, as you've seen here. Now, the reason for showing you this is the heat propagation in a tumor cannot be as elegantly controlled as radiosurgery. You cannot contour the heat exactly and precisely to the tumor volume, which you could do with radiosurgery, okay? And so not surprisingly, if you were, because of the inability to control, the heat propagation is determined by the cell density of the tumor, the vascularity around. There's multiple factors that we can't control that prevents us from achieving the same elegant contouring as we could do for radiosurgery. And so if you were to compare, right, repeat radiosurgery in the treatment of brain metastasis after failed radiosurgery, and if you look at LIT, the control rate for LIT for recurrent tumor is not great. You're looking at 30 to 60% at 12 months at most. And that's not surprising, again, as I mentioned. What we really, again, we have the ghost. Here we go. Let's move on to, again, the reason for the poor control has to do with what we discussed earlier in the first talk. There are microscopic tumors outside of the contrast enhancing region. This is one of my, I asked one of my students to take a biopsy of the cerebrum after I believe I achieved a growth total resection, and this is what's shown in the pathology, right? We don't know what's outside. We don't know what we don't know. And if you can't see outside of your resection cavity, there might be tumor there. The beauty of radiosurgery is you could contour a lesion, and there's a dose taper that extends beyond that region of micrometastasis that allows us to achieve better control. For LIT, for its laser ablation, we can't achieve the same contour, and therefore there's likely some residual tumor, which you heard in the earlier talk can be a predictor for local recurrence. So LIT as a standalone for brain metastasis doesn't make sense. You don't have the capacity for contour. What does make sense is the following in my mind. We do know from a large body of literature that there is synergy between the immediate and short-term effects of hyperthermia, and radiosurgery. Okay, so combining them may allow you to achieve improved efficacy. The second thing is we have come to accept laser ablation as a treatment for adverse radiation effect. The idea being the adverse radiation effect results from secretion of proteins and soluble factors that irritates the brain. And by ablating the region, you denature those various reagents and you essentially stop the irritation. So combining laser ablation with stereotactic radiosurgery may improve efficacy through the combination of hyperthermia and radiation. And it may prophylactically denature the proteins so that after radiosurgery, you don't induce the same radiation effect. With this as premise, we explored the following treatment paradigm. And this is work that's gone on for about the past 10 years. Every patient who has a brain metastasis that recurred after radiosurgery is reviewed at a multidisciplinary review. To this earlier, to David's point and there is value, and to Marcel's point, there's value in the input of radiation oncologists, surgeons, to provide the best possible care for our patients. So we review this. And if the review indicates a patient's appropriate for LIT plus consolidated SRS, and we did this under an IRB, we would perform the laser ablation, okay, do the best we can to contour the heat to the tumor. But then within 30 days, we would do a 5-gray times 5 radiosurgery. And 5 by 5 is so that we could be gentle. I think combining radiosurgery and in a single dose with lead may be too much. That's bore out by some of the experiences my colleagues have shared with me. So these are the patients who who underwent LIT followed by a 5 by 5 radiosurgery within a 30-day period. So let me see here. Why is it? Oh, there we go. So we published our first experience in 2016. We treated our first patient in 2014, and the results are quite impressive. This is a typical illustration. I don't know if you can see my arrow here, but in panel A, you could see this is a colon cancer, like the breast cancer that I showed you, treated with radiosurgery, shrunk and now re-expanded. There's some flare abnormalities. So we treat it with laser ablation. And what you can see here is that after laser ablations, there's typically an expansion in the volume. And within 30 days, we treated this with SRS. And this is remarkable. Of the 4 patients we treated in this initial series, every single one of these patients had volume expansion. And then you could see the tumor literally melted away, right? And you could see the flare abnormality went away. So we were quite impressed with this, and we started collecting more patients. And we, we're doing this again under IRB. So ultimately, we published this recent paper this past year, collecting about 20 patients who had brain metastases that recurred after radiosurgery, reviewed at a multidisciplinary board, underwent laser ablation followed by SRS within 30 days. Okay, you can see this is the distribution of the 20 patients. Here's an example of the outcome. You could see in SRS, there is the tumor after SRS, it melted away, and then it grew back a year. After laser ablation, you can see the typical kind of eggshell appearance. We gave SRS at that time. And this patient actually right now, she's now at 27 months. When we published this is only 19 months. And so we see many, many patients like this. And you can see the dosimetry of the 5 by 5, which is a larger volume than the actual metastasis itself. And again, it allows us to expand. This is the same idea as super radical resection, but this is super radical SRS, if you will. And so here's the outcome. Of the 20 patients, we have 2 recurrences, one at 600 days and one at like 1,000 days or 900 days, which is quite impressive, right? Now, again, if you die within a year of the metastasis coming back after radiosurgery, none of this matters, right? But for the people who have durable survival, you're starting to see this as a very powerful way to control brain metastasis growth. So after that study, we collaborated with the Duke group, and we collected brain tumor metastases that recurred after radiosurgery that were treated with lead alone, with SRS alone, because this is a multi-institutional experience and we all treat patients differently depending on our research interest. And then we had a cohort that had lead plus SRS. And you can see the local control rate in this area between adding lead to SRS is far superior. Okay. And what I would share with you also is that the amount of flare abnormality around the treatment site, this idea of prophylactic lead to prevent adverse radiation effect is genuine. And we reported that in this paper as well. So I'm going to conclude my talk and just propose to you that this is a option that should be considered. And in fact, there are 2 clinical trials in the United States, one by Medtronic and one I'm actually initiating as an investigator-initiated study. Those of you who are interested in participating in this study should let me know. We'd love to have you involved. The idea is to explore in a prospective manner the efficacy and morbidity, if you will, of lead plus SRS in the treatment of both brain metastasis that recurred after radiosurgery. And frankly, we're pushing this now to the upfront setting, because in many patients who had brain metastasis who need to be on immunotherapy, but also need to be on steroid, that's a big problem. And if we could minimize that through lead plus CSRS, avoiding all the flare that occurs after, that might be of benefit. The other thing is lead, in my mind, is increasingly replacing conventional surgery for the reason that systemic control remains the main challenge for patients with brain metastasis. And if you do surgery, you typically have to stop the therapy for some amount of time, some arbitrary amount of time, dependent on the surgeon. For these lead patients, I am letting my oncologist treat through lead because I do a 3 millimeter incision, and the healing, and there's no bone flap. So first of all, we've never had any infections. I've done now over 200 lead over the past decade. Never had an infection. But even if there's an infection, it's a skin incision. There's no bone flap to worry about. So I am letting my oncologist treat through the lead. And our radiation oncologists are letting, for the most part, immunotherapies and targeted therapies to be treating through the SRS, so we don't disrupt the systemic treatment. So at the end, I just wanted, this effort is a multi sort of disciplinary effort. These are all the members who participate in our multidisciplinary board who reviews these cases. And certainly this project would not be possible without the contributions of the folks who are listed on this list. With that, I'll stop and open myself up for any questions.
So thank you, Dr. Chen, for this very innovative talk. Maybe I can start with the first question. You mentioned the increased sensitivity to radiation therapy post-lit, right? So
Yes.
Could you even comment? I know there are reports out there on increased, let's say, chemotherapy sensitivity in brain metastasis post-lit as well, in terms of the blood-brain barrier being disrupted. Could you comment on that, please?
Yeah, I can't tease that out because I let my oncologist treat through my surgeries, right? So what you're observing is a combination of everything. And I don't want to tease it out as long as it works. It'll be an ethical dilemma, if on the one hand we want to know how much of what we're seeing is the increased blood-brain barrier penetration of the drugs. Remember the study that was done from WashU or UW? No, WashU. where if you do a laser ablation, the blood-brain barrier is breaking down for about 1 to 2 months. And during that period of time, you may have increased amount of penetration for the chemotherapy. And at the end of the day, as long as that doesn't hurt the patient, I don't need to know how much is penetrating. But you're right, I can't attribute the success of these local controls solely to SRS or solely to LIT, because the patients are being treated through these various modalities with systemic therapy.
Thank you.
And I'll tell you, the oncologists love it, because they're always concerned, and they rightly so should be concerned about, interrupting particularly targeted therapies. And, having a minimally invasive option is, in my mind, a great thing for the patient.
Definitely. So I think we have one question here in the Q&A. Do you radiologically differentiate between radionecrosis versus recurrence before retreatment? Yes,
Absolutely. Remember, we have 30 days between the lid is typically done with biopsy together. Okay. Now, there are some technical considerations there we could discuss if there's interest, and there's 30 days until SRS. If the biopsy does not show tumor growth, we do not carry on with our SRS. We leave it at, here's radiation necrosis, we lit it, that's it. Only if we have definitive and final pathology demonstrating tumor do we add the consolidation SRS. Now that opens up a whole nother can of worms, which is, did we biopsy the right spot within the tumor to get the tissue? And so there I've taken on, I trained with Peter Warnke, as you know, and so I've taken out his approach of just having a trajectory and doing serial biopsies of the lesion, so that we have increased representation with the goal of better diagnosis. But you can imagine if you have a tumor, right? This is something Peter and I talk a lot about, right? Do you biopsy this way serially or do this way serially? At the end of the day, that trajectory is determined by the safety of the surgery rather than by the biology of the tumor. And maybe someday, if we have better imaging, we could better define our biopsy tracks.
Thank you. So 2 more questions. We might have time for these 2 questions, I think. So the first one, what imaging modality would you recommend to distinguish between tumor recurrence and radiation necrosis? And a follow-up question to that, what is your threshold for surgical resection?
Oh, that's a great question. The first question is, the answer is every modality, because nothing's perfect. I think whatever you have. So at our institution, we routinely use spectroscopy as well as perfusion imaging. We do use advanced form of DWI, but none of these are perfect. I mean, PET is used from time to time when I have a question. So just know that we've actually done a comparison. We published a paper a while back where every patient underwent PET, ASL, perfusion, and spectroscopy. And the sensitivity and specificity of the 4 modalities, and then we biopsy, the positive spots. So this was published, I think, in the American Journal of Neuroradiology. If there's an interest, let me know. I could share that manuscript with everybody. And the bottom line is, with tissue diagnosis as the gold standard, the sensitivity and specificity of these 4 modalities is somewhere between 75 and 80 some percent. None of them's perfect. At the end of the day, it's the biopsy that drives. Now, what is my threshold for resection? Generally speaking, LIT is associated with post-laser ablation swelling. If the tumor is sizable, if the patient's symptomatic, if the brain is full, if the brain is non-compliant, and there are different criteria you could impose onto those 4 things, the patient probably would benefit more from resection than a laser ablation, okay? And in those patients, I don't have time to talk about this today, we have a form of brachytherapy called gamma tiles. So for those patients, we resect the tumor and put in gamma tiles, and thus far we've had great outcomes. And again, this is a study that we'll be doing with MSKCC, Memorial Sloan Kettering, to prospectively look at what happens if you resect and then adding gamma tiles to the resection cavity. And we could talk about that perhaps in a future talk.
Thank you. And a final question before we move onwards. What about treating radionecrosis with bevacizumab? Could you please comment?
That's a great option as well. I think that a 2 to 3 course with bevacizumab is something we often offer our patients. So what we're dealing with is a risk and benefit that we've shared. Basically, I present the option to my patients. Avastin has its own systemic harms, and you need to weigh that against the potential risk of a biopsy plus laser ablation. Generally, most patients want to know what they're dealing with. Remember, if you treat with Avastin and the tumor, it's a tumor rather than radiation necrosis, then you've not done the patient a favor. I think the value of definitive tissue diagnosis, it usually is the one that drives patients to laser ablation. We are finishing up a manuscript right now, and that demonstrates that performing a biopsy plus lid is no more risky or no riskier than doing a biopsy alone. So if there's no difference in the risk of biopsy versus lid versus biopsy alone, why wouldn't you want something treated? Why wouldn't you want to know what the tissue is? Now, there are patients who are deadly afraid of surgery. Brain surgery is scary. We do it every day, but it is scary. For those patients who do not want to know, do not want the surgery, I think that bevacizumab is a great option. But I don't know. I wouldn't want someone taking a guess on my brain if I were the patient.
Thank you. Thank you for answers. And again, thank you for taking your time to joining in on the webinar today.
Well, thank you for the invitation. I hope this is helpful to everybody. And like I said, if there's lit centers are interested in this study, please let me know.
Thank you. So Christian, will you present the next speaker?
Thank you. Last but certainly not least, we have Philip Blumenfeld from the Hebrew University of Jerusalem here with us. He's there treating lung and brain malignancies with radiation therapy and medical therapy. And he will give us the medical oncology perspective on treatment of brain metastases. Philip, it's a pleasure to have you here. Please give us our talk. Give us your talk.
Okay, thank you. So today I'm going to be discussing the evolving role of systemic therapy for the treatment of brain metastases. I come from the Hebrew University, part of Hadassah Medical Center. In terms of my disclosure, I guess if a neurosurgeon can give the talk on SRS, I'm a radiation oncologist by training, but one of my areas of interest is the utilization of novel therapeutics together with radiosurgery, and trained as well in medical oncology. So, and here are my other disclosures. So, as you guys heard today already, and as you all know, the historical management of brain mets is consistent of local brain-directed therapy, which involves either stereotactic radiation, whole brain radiation, and when indicated, it's neurosurgical intervention. But we're now entering into a new era of systemic therapy. And this new era potentially has these new systemic agents have the ability, many of them, to penetrate the blood-brain barrier and achieve therapeutic responses. And as mentioned by the previous speaker, patients are living longer, and there is more time for their adverse effects from local therapies to manifest. So today we're going to ask the question if we can continue to push what we refer to as the therapeutic ratio. So maybe 0 gray of radiation is enough for tumor cure, meaning maybe systemic therapy can replace or augment the role of radiation, neurosurgery for brain metastases, and maybe in certain patients, in those in whom may have multiple brain metastases and whom SRS is not appropriate, we can kind of change the paradigm, start with the systemic therapy and then only use radiotherapy or neurosurgical interventions in the salvage setting. I don't need to tell this audience, but patients with lung cancer have quite a high risk of development of brain metastases, both at presentation and throughout their disease course. And the world of thoracic oncology is changing, and it's changing quite fast. 50% of patients with advanced non-small cell lung cancer have a driver mutation that's targetable with an FDA-approved agent or on a clinical trial. And even those without driver mutations may be treated with immunotherapy, such as pembrolizumab, yielding very impressive survival results. So today we're going to start our story back in 2000s with the advent of tyrosine kinase inhibitors targeting EGFR mutation in patients with non-small cell lung cancer. These patients are typically about 15% of the patients presenting with non-small cell lung cancer. And already in 2003, CNS activity was noted in patients with brain metastases. And this actually led to a shift in practice without very significant data, delaying local treatment in some very select patients. But really in 2018, and most recently in this publication in 2020, we received the results from a trial known as the FLORA trial. In this trial, osimertinib, which is a third-generation EGFR TKI, demonstrated an overall survival benefit compared to first-generation EGFR TKIs. And this basically changed the standard of care treatment for patients with EGFR overexpressing non-small cell lung cancer. It's important to note that this trial was not a brain metastases trial, looking at whether or not we can omit local therapy. Very important to note. However, the authors did something very nice for us in that they did a pre-planned exploratory analysis of the CNS efficacy of osimertinib compared to the standard of care. Important to note that about 25% of these patients in each arm had received previous radiotherapy in the last 6 months prior to the study entry, and about 25% had more than 3 lesions. And what they found was that these patients on the osimertinib arm, the third generation TKI, had significantly improved objective response, 66%. And in fact, of those, a very significant number had a complete response compared to 0% of patients with complete response in those that received the first generation TKI. It also demonstrated, and this is important, that it reduced the incidence of first progression in the CNS from 15% to 6% in the osimertinib arm. And very importantly also, in terms of how we design potentially future trials, is that no patient in this had progressed in the CNS at 6 weeks. Indeed, here we see a radio-labeled version of the drug showing osimertinib on your left, very significant CNS penetrance compared to some of the other first-generation TKIs. The OCEAN study is a very recent study that came out in 2021 with a phase 2 study of patients with radiotherapy-naive CNS metastases, and then similarly showed an objective response rate between 66 to 70% with the median CNS progression-free survival of 25 months. Interestingly, most common mutations in non-small cell patients that have been identified in the EGFR gene are either those with an in-frame deletion at 19, exon 19, and those in exon 21, L858R. And it appears that those patients that have the exon 19L have improved brain met progression-free survival with the median survival of median progression-free brain met-free survival of 31.8 months compared to 8.3 months in those with the 21 L858R mutation. So it kind of teaches us here that there can be even significant heterogeneity in terms of the duration of responses for patients with EGFR mutation, similar to what we see systemically as well. As mentioned earlier, ALK mutation it's a relatively rare mutation than EGFR, somewhere between 2 to 5%. About 30% of these patients present with brain mets, and over about 50% eventually will develop brain metastases. So Shaw and colleagues recently were able to complete and present the results of a CROWN trial. And this phase 3 trial compared crizotinib, which is a more earlier generation ALK inhibitor, versus the more recent lorlatinib. And lorlatinib demonstrated an improvement in progression-free survival. But for our purposes today, we had a very impressive intracranial response of 82% with lorlatinib, and 71% of those patients with a complete response. Again, really, really phenomenal data. And while this study's primary endpoint was not CNS progression-free survival, we're definitely left with the very compelling data that potentially can cause here a paradigm shift in how we approach these patients. Similarly, in patients with another trial, brigatinib versus crizotinib, this is also a phase 3 study showing brigatinib also demonstrating a very impressive intracranial response, 78% versus those on crizotinib at 26%. And interestingly, a post hoc analysis showing that there may be an overall survival benefit for patients on brigatinib with baseline brain metastases. And these newer generation ALK inhibitors have now become the standard management in patients presenting with brain metastases. But still, we're kind of left with the question, right? Can we delay radiation using systemic therapy? So the data that's derived from these trials at selected brain metastases populations, mostly asymptomatic patients. There was significant heterogeneity in regard to whether or not the patients had prior radiation, and typically not a primary endpoint. And I think it's also really important to note the impact of progressive CNS disease on quality of life. And functional outcome is quite limited in these data. So we must ask this question, can we delay radiation using systemic therapies? So I bring you some retrospective data first in terms of the first generation TKI. This comes from Hopkins, and they took 351 patients with TKI naive EGFR mutated non-small cell lung cancer, and most received first generation TKI. And as you can see, those patients that appears in terms of their overall survival, those that receive upfront SRS appear to do quite well. Okay, at 46-month median survival and 78% at 2 years. And in terms of the median time, not shown here, time to intracranial progression, it was improved in those patients that either underwent stereotactic radiosurgery or whole brain radiosurgery versus first generation TKI. So this group may hypothesize, no, we cannot delay the radiation treatment, at least with first generation TKI. In this, however, recent retrospective analysis, looking at patients with brain metastases with either EGFR or ALK mutated non-small cell lung cancer who are now on the more recent agents, CNS penetrating TKIs, there was no difference in the time to intracranial progression in either the EGFR or ALK cohort, suggesting it may be reasonable to start TKI and delay radiation in select patients. It should be noted that those patients who received radiation were more likely to have larger, more symptomatic brain metastases and receive steroids. I actually find this study also retrospective to be, though, very hypothesis generating. And this comes from China, and it's patients with EGFR mutated non-small cell lung cancer who were treated on osimertinib first line. And what it demonstrated is that the addition of radiotherapy did improve intracranial progression, but it did not affect survival. However, in the patients that had limited brain metastases, the delivery of SRS together with the Tagrisso, or osimertinib as we call it, improved both intracranial progression-free survival, and it almost doubled, as you see here, their overall survival. So I know many institutions who continue to recommend SRS when patients do present limited brain metastases, even when they are, even if they're asymptomatic, and even if they are, if they do have a targetable lesion. So we're still left with the question, to treat or not to treat, right? We have on one hand, more potential tumor control with the addition of SRS, but then on the other hand, of course, toxicity, potential systemic treatment delay, although usually not much of an issue anymore. And then, of course, the cost of the treatment. We do have some open trials, two open trials, two phase 2 trials, looking at the addition of osimertinib, third generation TKI for EGFR mutated non-small cell lung cancer, plus or minus SRS, and we're looking forward to the results. I'm very pleased that in my center, we actually took a little bit different approach, and we've developed this phase 3 trial, which we have started to accrue patients, and would be happy to have anyone else on board if interested in their institution. And our approach is as follows. Consolidation radiation at the point of maximal response to systemic therapy in systemic disease is becoming a more established paradigm for extracranial disease in non-small cell lung cancer in patients with metastases. And the idea is that we are trying to limit the development of acquired resistance. So we took that same logic in the CNS, and what we said is we hypothesized that if we would start in patients with asymptomatic brain metastases, start with osimertinib, and then we do another MRI at 6 to 8 weeks. And then we are randomizing patients to either radiosurgery, to the residual disease, or osimertinib alone. And of course, any patient who would progress after these 2 months would not be in the study, and they would be treated with SRS, and those patients who have a complete response also would not be in the study. They would continue osimertinib alone. And we're looking at CNS progression-free survival. So here's an example of a patient who is enrolled in our study, came in at baseline with multiple brain metastases, and then on their follow-up scan, they had 4 residual brain metastases, and then the patient was randomized to either SRS or continuing the Tagrisso alone. So for now, what do? According to the ASCO, SNO, and ASTRO guidelines, it is very reasonable in patients with asymptomatic brain metastases from EGFR mutated or ALK mutated who are going to be receiving CNS penetrating agents to allow to delay local therapy until there is evidence of intracranial progression. However, it should be noted that this should be done after multidisciplinary discussion involving medical oncology, radiation oncology, and neurosurgical representation. And if local therapy is deferred, close monitoring is very crucial. And here I have a very nice slide from one of my colleagues demonstrating how a best schematic in terms of managing these patients. And so, those patients, again, who have symptomatic lesions, disease located in an eloquent area, or solitary lesion, appropriate local therapy should be definitely done. Those that are asymptomatic and whom have a CNS penetrating agent, it is very reasonable to start with a penetrating agent with very close surveillance MRI, and again, only after discussion in multidisciplinary tumor board. This is a very recent patient of ours. She's 30 years old. Totally asymptomatic, and she had a biopsy from her lung, and she came back ALK positive non-small cell lung cancer. She had a staging MRI. Again, she was asymptomatic, but she had a quite large left frontal mass. We were lucky here in that we were just days away from getting the genomic data, and indeed we waited for that, and we spoke with the patient. And in addition, she had 4 additional brain metastases, and we started in this patient with lorlatinib and a short interval MRI, and you could see already a phenomenal response to the ALK. The other 4 mets totally gone. What about those patients, non-small cell wild type without any driver mutation? So we look at the guideline, it states that pembrolizumab immunotherapy, which targets PD-L1, it can be offered to patients with asymptomatic brain metastases with PD-L1 expressing non-small cell lung cancer who are also receiving pemetrexed and a platinum agent. And this is based upon a subgroup efficacy analysis in patients with brain metastases enrolled on the Keynote 189. And that looked at the addition of pembrolizumab, which showed a survival advantage. It should be noted that patients were largely asymptomatic and a large portion of them were treated with local therapy. So the guideline does state here that there is no consensus to delay local therapy when pembro and pemetrexed and platinum agent is used. So the effect of systemic therapy on active brain metastases is unclear. The best level of evidence that we have in kind of a patient naive population with single agent pembrolizumab comes from this data from Sarah Goldberg. And basically it took a small cohort of patients, 42 patients, ECOG performance set as 0 to 1, in whom had at least one active brain metastasis measuring 5 to 20 millimeters. These patients had not previously been treated or had progressed after radiotherapy. Now, it did show about a 30% brain met response. Again, not too great compared to the other data that I showed you, and the duration was about 5.7 months. There is also some, not pictured here, but we do have some real world evidence as well that shows something similar to a brain metastases response, about 30%. Currently, again, the guideline states no consensus regarding the deferring of local therapy. What I think is what has been mentioned earlier, which is quite interesting, is the addition of immune checkpoint inhibitors to SRS. And in this study, there appears to be an improvement of the delivery of immune therapy together with their SRS in terms of local control. And doesn't seem to, although a trend, no statistically different incidence of radionecrosis. There is recently a meta-analysis of 19 retrospective studies showing that favoring radiation together with immune checkpoint inhibitor, not pictured here. Also, it showed that concurrent immune checkpoint inhibitor with SRS seems to be beneficial as opposed to sequential. As mentioned earlier, we really try to continue the therapy while they're undergoing their SRS. And then in terms of the radionecrosis, there may be in a meta-analysis, there may be a slight increase in radionecrosis in patients with non-small cell lung cancer. And this actually may be a little bit different than what we see in the melanoma data. And here's just a patient of ours that she was a 65-year-old lady. On the left, you see from 2 years ago, approximately, she came in with multiple asymptomatic brain metastases. Actually, a couple of them were on the larger size. We recommended for her actually hippocampal. She had no driver mutation. She did have a PD-L1 that was high. We recommended a whole brain radiotherapy with hippocampal avoidance in her. Well, SRS definitely could have been done, but that's more of our institutional preference. The patient declined, and as you see on the right side, she's now 2 years out with pembrolizumab and Avastin, actually used by my medical oncologist, without any evidence of disease in the brain. So this is something we very much like to see. Again, very anecdotal and not yet for prime time, in my opinion. We do have a number of trials that are ongoing, looking at the addition of radiation in patients that are going to be undergoing immune checkpoint inhibition. And we also must say we are local doctors. So what about other cancers? Okay, you told me enough about lung cancer. Here's some data in breast cancer in patients with HER2 positive, HER2 overexpressing breast cancer. in the HER2 Klein trial. And this trial was looking at a small molecule inhibitor of HER2 in patients that were heavily pretreated. And actually, this drug called tucatinib actually demonstrated a very nice intracranial response in a heavily pretreated with a very impressive CNS progression-free survival. And very recently in HER2, which is a trastuzumab and deruxtecan, which is an antibody drug conjugate linking a topoisomerase inhibitor with trastuzumab, actually demonstrated a very nice intracranial response, 73.3%. Again, not a big N, and there is some other data from other studies, the Destiny trial, showing similar intracranial response rates. And so this seems now to be more of the standard if it's available in your institution, not available to all, but in HER2 is definitely something that's showing very nice promise in patients with intracranial brain metastases. How about those patients with hormone receptor positive breast cancer? Well, CDK4/6 inhibitors and abemaciclib does demonstrate some intracranial benefit, but again, not very long median progression-free survivals. Moving on to in melanoma, advances in systemic approaches, including immunotherapy and targeted agents such as BRAF therapy, have definitely revolutionized the management of patients with melanoma and brain metastases. And there's this, we just aren't seeing these many patients in clinic anymore. And this is a prospective study of dabrafenib and trebatinib called the COMBI-MB study, in which they had 4 cohorts. You can see here. I'll get to the meat and potatoes. So the intracranial response rate here ranged quite nicely from 44% to 59% based on what subset a cohort. However, the median intracranial progression-free survival was quite short, 4 to 6 months. And it was reduced almost by half compared to reported progression-free survival in patients without brain metastases. And so often, definitely in patients that are symptomatic, local therapy, in my opinion, is a must together with these agents. And then recently, not so recently, but we have a recent update from the Checkmate 204 study in melanoma in patients with ipi/nivo being treated with ipilimumab and nivolumab. So ipilimumab targets the CTLA4 and nivolumab is PD-L1. So this is a dual checkpoint inhibitor study. And what this demonstrated in these 2 cohorts, one is symptomatic and one asymptomatic, that those that were asymptomatic, quite good objective responses, and those who were symptomatic, less good. So almost, and their median overall three-year survival was quite worse in those patients that were symptomatic. So again, I think I think what this teaches, at least my take home from this, is those that are symptomatic, again, we have to be quite cautious in these patients to tell them, oh, you can go ahead and go ahead with just local therapy alone. And integration together with local therapy, I think, is extremely important. So I've tried my best to take all this data for you guys and give you kind of the intracranial responses to these, because this is always changing. I mean, I created this about 9 or 10 months ago for a different talk, and it's changing. And so I think this comes to my take-home message. This is a rapidly evolving field. The development of new therapies, enhanced CNS activity is outpacing our clinical trial efforts to evaluate systemic agents. So what do I have to tell you? We have to be doctors, right? We have to take a multidisciplinary approach together, the medical oncologist, the neurosurgeon, the radiation oncologist. And we have to do a kind of a not one size does not fit all approach, okay? We have to think about what is the intracranial responses of the drugs, the number of metastases, their symptoms, the location, the patient's access to quick MRIs, not always able to, their treatment tolerability, their access to urgent interventions, the reliability of the patient. And of course, patient preference is very important, but as physicians, we have to help guide them. So here are some last conclusions. Patients with brain metastases that are solitary or symptomatic, located in eloquent area, should be offered local therapy, in my opinion, irrespective of their presence of driver mutation, at least for now. Patients with asymptomatic brain metastases and no appropriate CNS penetrating agent should be offered appropriate local therapy. And then those well-selected patients, clinical trial enrollment is very much encouraged in those that have CNS penetrating agents available, and local treatment may be delayed only after MTD discussion and appropriate MR surveillance is in place. Thank you.
Thank you, Philip, for your great talk and putting together such a complex topic in such a good way. There are some questions in the question and answer box, and I'd like to start with one question. So you showed us some very stunning responses by third generation TKIs. You mentioned that in some points, in some patients, you might refrain taking a radiosurgery or radiotherapy in those cases because of the medical treatment response. So how important for you is to get histology or new tissue or panel sequencing of those brain mets? So how do you, for example, how do you forecast the response just from the primary tumor, or do you want to have?
Yeah, it's a very interesting evolving field. There definitely is data, as been mentioned, that we can see a different genomic profile in the tumor in the brain or in other metastatic sites. You can see acquired resistance as seen before to radiation. That being said, you have to take the whole picture, so then what happens, let's say we do a neurosurgical intervention. Let's say we take resection. So then it comes back and then I learn that it's EGFR positive. Should I give radiosurgery to the cavity? Shouldn't I? These are questions we don't know. In our practice, we do. My concern is that the drug after surgery may not penetrate as well, and so again, it's not at the initial start of presentation. If for me, it's more important to get the patient going on his systemic therapy and then doing quick surveillance within those 6 to 8 weeks, making sure that tumor is responding well to in the brain, because we don't want a catastrophe on our hands where the patient begins to progress locally. So it's a great question, and it's kind of open.
We have one more question by Dr.
In the patients that have already been on therapy for quite a while and who then start to progress, as mentioned earlier, maybe getting, again, depends where it is, what the status of the patient's performance status, how much time is that going to delay them from continuing on their systemic therapy. These are important. And then something I didn't really mention as strongly, but it's very important, especially those patients that are undergoing immunotherapy, that we want to get them off steroids as fast as possible. We do not like steroids. My medical oncologists hate steroids. They hate them. And they even, and we love them and they hate them. But, it's important now as we work together that these are considerations. So if the patient has a very large tumor that's causing significant edema, and I'm concerned that you're not going to get off of steroids fast, so maybe surgical intervention is required. Again, a case by case. These are becoming more and more complex, and we really have to discuss it in a multidisciplinary fashion.
If I could augment one comment, which is that it is fundamentally important to keep in mind that resection in terms of tumor removal is an absolute maneuver, meaning if you remove 1,000 tumors, it's 1,000 tumors, right? If you treat a tumor with targeted therapy, it's a proportional kill. It's not an absolute kill. I think there will always be a role for some form of surgical intervention for the larger tumors, because if you have a 10 to the 22 cells and you could kill 99.99999%, that residual amount, if it's the base denominator is 10 to the 22, is still significant and it could still mutate. And we know the effect of many of these targeted agents are not durable. There will be mutations that evolve just by purely the effect of clonal evolution. So keeping in mind, I think as we make this decision, the fundamental principle that surgical kill is absolute. Chemotherapy kill and radiation kill is proportional. And that should factor into how we make our decision as well.
We have one more question in the question and answer box, which is the combination of radiosurgery and immune therapy or targeted therapy. Would you reduce the dose for the treatment of multiple brain mets?
So it's a great question, really, really great question. Here you see this pilot study that's undergoing now with 3 dose levels of SRS for patients with melanoma. So you're right on. It's a great question. We don't know. I don't. But again, I'm more likely in my practice than some of my fellow physicians. I'm very in favor of of doing 3-fraction SRS if it's definitely if it's an eloquent area, definitely if it's large. But maybe multi-fraction SRS can help reduce long-term rates of radionecrosis, maybe improve local control. We don't know, and it's open. But currently, no, we do not change the doses just purely based on the addition of immunotherapy at the time, at least not in my practice.
Thank you. I can't see any more questions, so I would like to. Oh, there's one. Sorry, Christine.
Sorry, one last question.
Coming up.
Thank you very much for this very nice talk. You pointed out that it's essential that you keep the patients on targeted therapies or immunotherapies, that you should not refrain from this therapy. And I think we as neurosurgeons are afraid of surgical complications such as wound healing, because most of those adjuncts are not known to us. So what's your opinion on that? Should we keep the patients on those therapies while doing surgery, or any recommendations?
I think it probably depends on what agent we're talking about. But most of the time, again, it's kind of an unanswered question in which we definitely and I don't have a good answer for you. There's definitely, and at least to my knowledge, there isn't great data to tell us what to do. I can tell you in patients in whom I give lung radiation while they're on Tagrisso, and this is happening ever more and more. Even amongst the radiation group, extracranial, there's those that continue the osimertinib, and I personally hold it for 2 days and hold it 2 days before and restart it 2 days after. This is total, anecdotal and kind of what was brought down from above. But I don't, and so similarly, we don't really have really great data to guide us, at least that I'm aware. What we do know is that we want, in the ideal scenario, once the patient has recovered nicely, to get back going with systemic treatment. And again, this will depend on what is there, I know we like to think from right here and above, but what else is going on below? And so these are all very important things in terms of how we would make that judgment call.
Thanks.
So I'd like to take the opportunity to thank all our speakers for the great talks and for offering the time, and all the people who listened to this second neuro-oncology webinar for sticking with us and trying to learn something new about brain metastases. I'd like to say that in next year we will have at least 3 webinars starting around April. So Stay tuned, and I'd like to ask Matthias for his closing remarks, please.
Well, thank you, everybody. Thank you to the speakers. I have learned a lot today. It was very interesting. I think we're on a good way. And as Christian mentioned, please stay tuned. We'll have a couple of exciting events next year as well. So now we're finished. Thank you very much. Bye-bye and have a good evening.